In this session, we'll be looking at two lung specimens. The first specimen was obtained from a 50-year-old female who suffered from bronchopneumonia. She presented to hospital with an intracerebral hemorrhage and died 20 days after admission. Blood cultures taken prior to her death revealed E. coli growth. The second specimen that we're going to look at is from a 47-year-old male who developed severe suppurative bronchitis with multiple abscesses. The patient had experienced repeated colds for a few months. 2 weeks prior to his hospital admission, he presented with an attack of influenza, with the typical characteristics such as cold, cough, yellow sputum, and rigors. Whilst the attack had cleared up, symptoms returned 3 days prior to his admission, where he was breathless, cyanosed, and febrile. A friction rub and harsh vesicular breathing was heard at the right base. A chest X-ray also revealed patchy consolidation and of the right lung and lower lobe. A neutrophil leukocytosis of 24 × 10⁹ per liter was observed. The patient then died 2 days later. The first lung specimen is a section of the right lower lobe. We can see several small pale foci of consolidation throughout the whole lung. As you can see here and here, they are mostly prominent in the subpleural lobules. Whilst the whole lobe is hyperemic, the parenchyma does not appear to be consolidated between the pale foci. Within the pulmonary arteries, there are two antemortem thrombi can be seen. One is near the center of the specimen, and the other is in the lower right section. The pleura remains unaffected. The appearance of the specimen resembles early-stage bronchopneumonia. The second lung specimen is visibly more consolidated. Whilst the upper lobe features multilocular abscesses with thick yellow walls surrounded by grey necrotic material, the rest of the lung contains a mottled grey and yellow areas confluent of bronchopneumonia. Unlike the first specimen, this lung is congested between the mottled grey areas, as you can see here, here, and here. The bronchial mucosa is also congested, and fibrinous exudate is present on the pleural surface. You can see that here.
We will now discuss the microscopic appearance of bronchopneumonia. The slide we see here was prepared by staining a biopsy of the lung tissue with hematoxylin and eosin. Microscopically, we can see evidence of severe confluent bronchopneumonia with necrosis of alveolar walls as well as abscess formation. We can observe alveoli containing edema, fluid, and inflammatory cell infiltrates, including many neutrophils. The alveolar walls will also appear congested, and in some sections you will be able to see both cellular and fibrinous exudate within the alveoli, as well as early organization of the exudate. In this specimen, we can also see focal tissue destruction and congested vessels. In healthy individuals, bronchopneumonia is more common and tends to affect patches of the lungs, while those with decreased immune status typically get a diffuse and confluent lobar pneumonia, as it is easier for the bacteria to spread. However, the exception is strep pneumoniae, which has a capsule, and this enables it to escape phagocytosis and replicate quickly in the early part of the infection, stimulating a larger immune response in healthy individuals and leading to more exudate and a lobar pneumonia. In fact, strep pneumoniae causes 95% of lobar pneumonia cases. In a different section, we can observe the typical signs of red hepatization, that is neutrophil infiltration, red blood cell extravasation, and fibrin deposition. We can see hemorrhaging and loss of anatomical structure throughout the tissue and necrosis in the top right-hand corner of the section. At a higher magnification, we examine the abscess in more detail, and we can notice focal necrosis with a central necrotic area in the middle of the tissue that may have once been a bronchiole. Within the tissue, we can see evidence of hemorrhaging and fragmented nuclei. Importantly, there are no live cells left in this tissue, nor any of the original tissue organization.